No YouTube?
YouTube.
Pode começar no YouTube já.
Começamos no YouTube também. So, we just started, Dr. Annie. Thank you very much for being here with us. Pessoal, hoje eu vou falar com a doutora Anne Uriarte.
Oi, pessoal.
Ela é diplomada do Colégio Europeu de Neurologia e ela é professora na Universidade de Tufts. E a gente vai fazer essa live em inglês. E eu vou tentar traduzir para vocês aqui alguns pontos chaves das respostas da doutora Anne. Então, eu vou me apresentar e vou falar um pouco com ela agora sobre essa live.
Vocês podem ir colocando no chat. Pode colocar em
português. Perguntas podem ser em português, no chat, que eu vou traduzir para ela. So, Dr. Annie, thank you very much for being here.
I kind of understand a little bit Portuguese, particularly with your accent, so should be fine.
Awesome, awesome. Thank you very much. So, Dr. Annie, today we're going to talk about neuro-radiology. Pessoal, a gente vai falar de neuroradiologia com a doutora Anne, então muito massa. O radiologista tem que saber de neurologia. But the first thing I want to know is, why did you choose neurology?
Okay, so maybe you should I answer in English or in Spanish? What would people prefer? Because I know that the last time I was in Brazil, a lot of people prefer Spanish, but I don't know.
Well, I really have trouble understanding Spanish. You're from Spain, right?
Yeah.
You guys speak so fast, I cannot understand at all. Like, and I'm like, what? I was in Spain last year and I couldn't understand like nothing. So please answer in English so I can try to translate it. But first of all, thank you very much. And are you okay? Everything's fine with you in the pandemic?
Yeah. Okay. Yeah, no, you see, life in the States, in Westbury is very calm. So social distancing is very easy. It's a normal day. You don't see anyone in the street anyway. So it's like a normal day.
So why did you choose neurology? Pessoal, perguntei para ela, por que ela escolheu neurologia?
Yeah, no, thank you very much, Tiago, for inviting me. And I choose neurology, and that's also like the question that I asked you last time when we were talking. I was not a great student at vet school, and I had the feeling that when I finished vet school, we knew about nothing. Like I didn't have the feeling that we could really do anything. And I just felt that I needed to be doing something a little bit better. And then I was lucky to do my Erasmus in France. And a teacher of neurology was very, very good, who later on, he was my supervisor. So I just understood neurology very well. So, when you understand something and you feel that you were a little bit good at it, then it's just organic. And then you just like it because it feels that you're better. And then, yeah, that's how it happened.
Awesome. Então, pessoal, ela respondeu que escolheu neurologia porque tinha uma afinidade, conheceu professores na área que ajudaram ela também a desenvolver isso. Então, quando isso acontece, é fácil, né, seguir nessa área. E isso aconteceu comigo também, de certa forma, com diagnóstico por imagem. Awesome, awesome. So, Dr. Anne, what do you think does the radiologist need to know about neurology? Because I've seen, like, in some places that I've been, that the neurologists were doing the report of the MRIs, the brain MRIs, and all of that. Do you think that's a little awkward, or it should be like that? What do you think?
So I think that it has to be complementary because, and I can actually, we can look at a little, just I would like to share just a screen, just 1 second, to show you something that I think that is important when we think about, obviously, not only about neurology, but when we think about using or doing any specialty. When we're talking about neurology, our neurological examination is going to tell us what part of the nervous system is affected. But then, as a clinician, you need to think about epidemiology, clinical history, and progression, and that is going to give you your top 3 differential diagnoses. And you do a test not because you are fishing, not because you want to find something, no, because you want to prove what is one of your top 3 differential diagnoses, is it real or not? So that's when you're going to need to be choosing your diagnostic method, and then you're going to interpret. So I think that as a radiologist, what I like what we get from our radiologists here at TAPS is that you have a very nice description of what do they see. And they are not only looking at the disease they have in mind, which because I have already a disease in mind. So the radiologist is going to be describing objectively what they see. And with their objective description, they're going to come up also with 3 differential diagnoses. But then as a clinician, the clinician needs to be using this epidemiology, clinical history, and progression to come up with the 3 differential, and then they combine together. So I think that it's extremely important that your clinician is helping you to localize what part of the nervous system you need to looking for, and then you need to interpret your diagnostic findings based on your top 3 differential diagnoses. I think that interpreting an MRI or a CT scan without a clinical history, I think that it just doesn't make any sense.
Awesome. So, pessoal, eu perguntei para ela o que o radiologista precisa saber, né? E o radiologista realmente precisa interpretar a imagem, associar com os sinais clínicos e ajudar o neurologista também. Mas ela falou que o neurologista que vai fazer o diagnóstico baseado também na associação dos sinais clínicos. Então, basicamente assim, o radiologista tem que entender de neuro para conseguir conversar com o neurologista, né? É uma área que a gente precisa ter essa troca acontecendo, tá? So, Dr. Ane, one thing that... e agora eu vou falar de uma situação aqui do Brasil, gente. Por que algumas vezes, alguns veterinários ou algumas situações, a gente pode ficar com dúvida e receber uma solicitação de coluna inteira, por exemplo, né? Então, vou perguntar para ela se ela já viu essa situação e como que ela lidou ou o que a gente deve fazer nessa situação. So, Dr. Ane.
Yeah, I got the
You got
question. Yeah. So I think that is a very, very good question, because I will say that the most common radiology mistake that I see is taking the X-ray of the wrong part of the spine. So we know that when we are doing an anatomical localization, when we're thinking about the spine, we're going to be having C1, C5, C62, T3, L3, L4, S1. And that is going to be related to how many legs are affected, so if we have proprioceptive deficits in the forelimbs on just the back, and then if you have normal spinal reflexes or not. So the most common mistake I see from a referring vet is that the neurological examination says that the dog has proprioceptive deficits, for example, in the hind limbs and normal spinal reflexes, which will be typically of a T3, L3 localization, and they send me one X-ray of the L4, S1. So that is extremely important, and there is absolutely no point of taking an X-rays of L4, S1 when your dog had, for example, normal spinal reflexes, or if you are looking, for example, at viscospondylitis and you have a localization of T3, L3, there's no point of also doing only from T10 to S1. You need to do the full T3, L3. So we have that 2 situations, which is a very common mistake, and it's a shame because doing X-rays is not cheap either. It's not easy, and you just need to choose the right localization for sure.
Awesome. So I faced a situation like this once, and Jean from Bioethicals, and he taught me a lot about neurology. I have a very, superficial knowledge about radiology because I also practice acupuncture. And once I got into to do radiographs for these patients, and I could see it that he had like no atrophy, that he had like hind limb paresis, but they ordered like thoracic and cervical thoracic radiograms. So I'm like, oh, this is probably wrong, right? Because it should be like thoracolumbar or,
Yeah.
And I'm like facing this dilemma. what should I do? Should I do the exam? And I think that's not really helpful for the patient, or should I call the neurologist, the clinician, and talk to him? What do you think is the correct approach about that?
Yeah, and I don't face this problem at the moment, but I used to face it a lot when I was a resident in Paris, where the relationship with the vets and the university was not as nice as it can be in the States or it could be in UK. So there was a little bit of a competition, and we will have a similar situation, I will say even worse, when you will have a dog that will refer to MRI to do a study of T3L3 when it was a Doberman, that although it only had proprioceptive deficits on the hind limbs, you knew that that dog was a C62, and you knew that that dog was a wobblers. So doing an MRI of a T3L3 was completely pointless. You were going to put the dog under anesthesia. You were going to keep the dog with a low field MRI, a long time anesthetized, and doing an MRI that it was not the right site. So we had the approach of, we were lucky that the person doing the MRI knew a lot of vets, so she knew which vet will accept that phone call. And we would try to do the phone call and say, look, we think that this is what you need to do. But we were lucky that we had a neurology service, and we were, so this, the radiologist, she will call us and she will say, guys, could you come to see this dog? I don't think that this is the right localization. Can you do a neuro exam? Can you support me on this one? But I agree that it's a difficult one. And it can be both ways. You can have someone that is asking you too much or too little. If you're looking, for example, for a polytrauma patient, you know, or for a discospondylitis, you know that you need to do the full spine, even if your localization is one area. But if you're looking, depends for what you're looking, then there's no point of doing the L4S1. If you're looking, yeah. So, yeah, I will think that speaking with the referring vet will be the ideal thing, but then you need to be feeling confident of your neurological localization, and that is not always easy if you're not a neurologist.
Awesome. Yes, I feel much better now, because that's what we try to do as a radiologist when we don't actually kind of agree with the exam and we want to help. So I think that's a radiologist's duty, right?
Yeah.
To talk and communicate. As for the clinicians, once the diagnosis for the radiologist is not quite right, we want to receive this feedback, right?
Yeah, exactly.
Então, pessoal, eu perguntei uma coisa muito corriqueira que já aconteceu comigo, né? Que eu recebi um paciente que ele tinha um sinal clínico de uma lesão tóraco-lombar e estava solicitado um exame cervical. E aí a conduta que eu conversei com a doutora Ane é o que a gente deve fazer. Realmente a comunicação é a chave e a gente deve ligar e comunicar e trocar essa ideia com o clínico e com quem tiver acessível, né, para receber essas informações, da mesma forma que o radiologista, quando erra um diagnóstico, precisa de um feedback também. So, Dr. Annie, what do you think are the pitfalls, for with advanced imaging? What are also what are the advantages with the advanced imaging?
There are few, and I can give you like an overview, and then we can go through some examples. I can show you some things that you can see, you cannot see, and what are the tricks. I would say that one of the also mistakes that I see very often, so we discuss about the X-ray, which is taking the wrong anatomical part, which obviously for MRI, CT will be the same. I have a little bit more experience with MRI than with the CT. The big mistakes that I see on CT, I have a lot of friends in Latin America that they are using MRIs, technicians from humans and humans machines. So they have very good machines. They even have a high field MRI, 1.5 Tesla, and they have horrible, horrible, horrible images. So when you have a 1.5 Tesla, you need to have a spectacular image. And what are the most common mistakes that I see? Positioning of the animal. I see that animals are not straight. Animal needs to be on MRI perfectly, and on CT is the same. You need to have a perfect position, and I'm sure that is the same for the X-ray. Perfect position, perfectly straight. We tend to do, for the MRI, we tend to put them on the back with like legs all extended and attached, perfect straight. You can put some sandbags on the side. And then you need to know your coils. So when you do an MRI, you need to know which coil are you going to use for what. In humans, they use completely different coils. So we use, for example, knee coils for the brain. And depending if it's a Siemens or if it's a Philips, there are different type of coils. I'm more than welcome to help people with the coils. But you need to know the coils. And what I tend to see a lot is people try to do the full dog in one sequence. So the MRI, I feel that is a little bit like an ultrasound. So an X-ray is really similar to me like a CT. Yeah, you obviously need to know what part of the CT do you do, but at the end of the day, you press one button and the CT takes plenty of X-rays. With the MRI, you need to know the technique. You need to know what is the segment you're going to do, how much you're going to reduce the field of view, and how are you going to play with your sequences. So you need a technician, and you need to know how a good MRI should look like. So you tell your technician, because I'm talking about having human technicians doing brains, and tell them, no, this is how it should look like. And then you need to do the cuts. You need to follow veterinarian cuts, not human cuts, because for the brain, we do more in humans. They do more like coronal cuts, and we do more like transverse and sagittal cuts. So there are papers that describe where the cuts are. And another very important one, always do the same sequences, because then you can compare your cases one-to-one. Don't do in one case, I'm doing a T1 transverse, a T1 dorsal, a flare. No, make yourself a protocol. There's a lot of protocols out there which have been published, and you say, okay, I'm doing my protocol. Every single patient, I'm doing my transverse at the same level, my dorsal at the same level, so you have a consistency with what you are looking, and you get used to your own images.
Good, great. There's one question. Is MRI done under full anesthesia or just dextromidor?
So for the MRI, they need to be really full anesthetized, and you don't want them to wake up. Why? Because you want to link one image to the other. So if your dog wakes up in the middle of the study, then you cannot link one image to the other. And remember that this is the difference with the CT. With the CT, you only take transverse image. The sagittal and dorsal, they are reconstruction from your transverse, but there is only one cut on CT. On MRI, you have transverse, dorsal, and sagittal. And for them to be linked, so if you have on your screen more than one image, they are linked, but then your dog cannot wake up between each study. So you do a scout, kind of tells the machine the position of the animal, and all the sequences needs to be under the same anesthesia. If he wakes up, you need to reposition, you need to do a scout, and then your images are not linked. So then it's not going to be that easy you're not going to be able to do exactly the same cut at the same level. So I will recommend, if possible, full anesthesia for sure. And then some people, they do fixed anesthesia or inhalation, depending on what is your possibilities, of course.
And Winnie is also asking DV, VD, or for VD or DV? I think it depends, right?
Yes. So for the brain, I always do. So we tend to put the head. So dorsal. I don't know. So the sternal position for the brain. For the spine, I really prefer the ventral position, because then you can extend the legs and then really stretch and have a straight spinal cord. That will be my recommendation. It's a little bit easier to have a straight spine when the dog is on a ventrodorsal position.
Muito legal, pessoal. A doutora Anne falou algumas coisas muito importantes aqui, e para quem não entendeu muito bem, o posicionamento, assim como na radiografia, na ressonância magnética e na tomografia, também são primordiais para que a gente consiga ter um bom exame, né? E existem protocolos que já foram publicados e deve-se seguir esses protocolos para que a gente consiga obter um diagnóstico adequado, tá bom? Dr. Annie, do you recommend any book for MRI?
Yes, actually, I don't know if I have the name here. I should have looked this before. So I don't have the name. So my residents have them. I don't have the name. I'm sorry. I will send you the link. So I use one human. I like it a lot, but I don't have it with me. It's in my office. There is one human one that I like a lot because you have not only diseases, but also finding. So for example, you say, okay, T2 hyperintense with T1 hypo, whatever. And so it's a little like a little dictionary. And then there is a very good veterinary radiology. Let me just look. I'm sure that I'm going to find it. MRI.
Yes,
because it's a very common one. Yeah, this one, the diagnostic MRI in dogs and cats. Yeah, exactly, that one. Yeah, that's the one that we have all the time. I personally, so that's the ones that my residents are always looking at. I'm not saying that sometimes it doesn't give me ideas. To be fair, I tend to be looking more online and on these human books. So usually I feel very comfortable with my differential diagnosis. So I tend to be looking more in humans to have like a different ideas. But yeah, that veterinary one is a very good one, very, very good one about, our residents, they use it a lot.
Great. So do you have any cases that you would like to show us where these pitfalls happened, or anything that you would like to share with us?
Yeah. So I kind of put some images of some examples, and then obviously you stop me if there is any questions or anything, just to give you some little examples of things that I am obviously completely obsessed with MRI, and that's what I do all day long, more than CT. But of course that CT, it has its space. Let me just see. Okay, so okay, so now you can see this, right? That's what we were talking about. Okay, so in general, when we're talking about a spine, CT versus MRI, we know that CT is extremely fast and it's less expensive, and then you could, even in certain cases, even do just a heavy sedation in an animal and do a full spine CT. But remember that you only have transfer images and the rest are reconstructed. So it's not going to be very accurate for anything that is intraparenchymal, intraaxial. And if you're looking, for example, for a compression that is not calcified, then you may need to do myeloscan. And the MRI, we all know that very, very good for soft tissue, but then if you have a low field, can take a little bit of time, and it can be a little bit frustrating if you have a low field. So when we have a lesion like this, we all know that we can do a myelogram, we can do a CT. We are going to see this huge compression that we see on that C3, C4 intervertebral space. So this is an easy one. We don't need to have an MRI to recognize something like this, but it's when we are looking at more intraaxial lesions. For example, on this lumbar spine, this is the sacrum, this is L7, okay? So we have a sagittal T2 view. Is T2 because the fat and the CSF is bright. On T2, two things are bright, CSF and fat. On T1, one thing is bright, only the fat, because the fat is more difficult to get rid of. So, for example, on the MRI, if someone was doing a myelogram, they could be thinking, oh, do I have some bulging there? But actually what you see is that you have an intraaxial lesion at that level, and you can see that gray matter that is affected. So this is a very good example of, first of all, how do you interpret these images? You know that these are incidental findings. Why? Because when you're going to have this MRI, your clinician is going to tell you this dog had a peracute asymmetric presentation and it was non-painful. So my top differential diagnosis is a vascular disease. So that's how, as a radiologist, you know that this is an incidental finding, because you need your clinician to tell you what's going on there. The same, we have the same one into a cat. So these are lesions that there is absolutely no way you're going to be able to see them with a CT or with a myelogram, particularly this one where you don't really have a lot of edema. And then we have these, now we are recognizing more and more these cases of the low volume, high velocity disc, where you see on that sagittal view, you have a nice dorsal column of CSF and fat that is still there, and you have a tiny bit of a ventral disruption of the ventral column. But then when you do a transfer image, you can see that it's a tiny bit of disc that is sitting there. Is this disc compressive? No, this disc is not compressive. This disc has only created this vascular myelopathy, has created a trauma into the spinal cord, but you don't really need to do a surgery on this. But you can see how all the epidural fat and the CSF is not nice and clear. Why? Because there is some kind of inflammatory and a little bit of edema around the spinal cord. So these are things that are important to recognize, because you're going to need to decide, is this dog going to need a surgery or not? And as a radiologist, sorry, I don't know why they are trying to continue the images. So as a radiologist, sorry, you need to also know when a compression is a compression that is big enough that needs surgery. And that's when you need to, someone needs to have experience, whether the neurologist, whether the radiologist, they need to know what is a compression that needs surgery. And I think that is what a lot of times as a radiologist, you're going to get a little bit stuck saying, okay, how do I interpret this compression? Is this something that needs to go to surgery or not? And I will say that that shouldn't be the call of a radiologist. That should be the call of the neurologist. Awesome. Of the clinician.
I agree. Great images, by the way. Where are those from?
These are from our MRI, our 1.5 Tesla. It's not even, now we have the 3 Tesla, so we should be even better now. Let me show you some other, okay, can you see? Can you see now?
Yes.
Yeah. So then the other also big ones that, like a big difficult ones that we have right now are these hydrated nucleus pulposus extrusion. When you see that actually the disc is not dehydrated, it seems that it's compressing the spinal cord, but it's hydrated, it's like a gel. So these are the discs that probably on the myelogram, I don't think that I will expect that probably the contrast will go through it. And these are the big ones that we always kind of really think, do we need to remove them or not? So look on this one, for example, this hyperintensity into the gray matter, because you have an acute compression or acute trauma. But a lot of these dogs, they don't really need surgery, although the spinal cord seems very compressed. So this is going to be tricky. And this definitely, you're going to need the conversation with your clinician. And in my opinion, the radiologist shouldn't be giving the call if the dog needs surgery or not. It can obviously help with their experience, how many cases they have seen, but it has to be the clinician to know neurologically how affected is the dog.
Yes, I agree completely, yeah.
This is just an example of an intraparenchymal bleeding of a dog that, a disc that extruded inside the spinal cord. Again, if you do a myelogram, you're not going to see anything, just going to see a stop of the contrast. With the MRI, you know exactly that there is an hematoma inside. I think that this one, you could even see it on on the CT scan. And I just want to put this image, and I think that this is a very interesting image of a spine where you have two lesions. There is a big lesion there, there is a compression, there is a disc extrusion. If you will do this on a myelogram, you will see that there is a compression here, but then what will you miss? This one. This huge FCE, this huge intravascular myelopathy, vascular myelopathy that this dog had. This dog, actually, following some of the papers that have been published, this dog had no deep pain. This dog has very, very little chances of recovering again. And the disc that he has here may be doing something, but there is another big lesion that we would have completely missed on the CT scan or on the myelogram. So these are a little bit the reasons why, yeah, we do an MRI. But here, the difference will be that your neurological examination will be different. This will give you a reduction of spinal reflexes, and this one it wouldn't. But then one is going to kind of make the other one a little bit difficult to localize.
Wow.
And then we have this one.
Great case.
This one, obviously I'm not going to start asking any questions, but this is an X-ray of a dog that had a tree fell over him. So I'm going to give a little bit of time for people to, I know that it's only one view, but it's a dog with a trauma, so we cannot take plenty of views. So I don't think that is an obvious change at all. So then this dog had a CT scan. And we see a little step there, okay?
Yes.
We see these little steps, but actually I haven't put you the rest of the CT, but he did not have any fractures at all. So if we follow the theory of the three compartments, we have a dog that, okay, he had a step, but he did not have any other fractures. Typically, that steps, they tend to have some articular process fractures or something. And we know that if two compartments are not touched, the animal should be stable, but it wasn't. Look at this MRI. So this dog, what happened is that there was a completely fracture or disruption of the intervertebral disc. So this is a very, very good example where we tend to obviously do a CT for a fracture, for a trauma, completely agree. And definitely on this case was helping us to see that step that on the X-ray was not that obvious at all.
Yes, not at all. And it's close to the anticlinal space, right?
Exactly. So we are having it here. So we have also the interposition of the two ribs. So you don't really see the canal very well. You tend to look at the articular process to see if there is kind of the joint, but here the articular process are very low. They are not big. Here is much easier to see them. Here, not that well. But this doesn't seem that bad. Doesn't seem that bad at all. But then when you do the MRI, that spinal cord was not happy at all. And that was really compressed. So these are special fractures where the disc is affected. And remember that the disc, actually, this was a two-compartment fracture, but it was affecting the disc, but not the vertebral body. And the disc creates a lot of instability there. So this could be like a very tricky case that we will all tend to do a CT scan or think that X-rays are enough. And actually with this dog, the MRI was extremely, extremely useful.
Awesome. Great case. Wow. I'm amazed how radiographs are so, sometimes they don't help at all, right? Because, like, oh, there's no lesion, there's no fracture, but X-rays are limited, especially on like vertebral body fractures or something, So it's amazing. how do you progress on the diagnosis? You started with the X-ray, you went to the CT, and then the MRI. So I believe you first have to, walk before you run. So that's the same thing with the diagnosis, right?
Yeah, I think that, for example, for the fractures, if we have, I mean, this also depends who is going to be the surgeon and what type of fracture you have, because it's true that sometimes you have an obvious fracture on the X-ray and it's a relatively easy, and you know that the technique you're going to use surgically is not going to change much. So you may be even happy to only have an X-ray if you have a dog that is neurologically, for example, is still walking. You have a big fracture that you know you're going to put some plates and nothing too complicated. On this case, it was a little bit more because the dog came already sedated. We couldn't really have a neurological evaluation. It seems that it didn't seem unstable on the CT, but then the next morning, so the dog woke up from the CT and we were saying, okay, let's see how he is. It doesn't seem too bad. The next morning, he was plegic. He had no voluntary movement. So that's when we did the MRI. So you need to balance the neurological examination, your neurological status, and see if you need to go further. If you don't see much on the CT and your dog is plegic, you need to do an MRI. There's something else there.
Ok. Então, pessoal, ela mostrou um caso bem interessante, onde houve uma progressão dos diagnósticos, começou com a radiografia e com a tomografia, num paciente onde uma árvore caiu na coluna dele, né? E a ressonância que evidenciou melhor a lesão mesmo, tá? Annie, I'm going to ask you a question. Maximiliano is asking, can you show us some typical hernia of the disc? I'm not sure if you came prepared for this kind of question, but he's asking that.
Yeah, look, what I'm going to do, we're just going to actually go together. I'm going to share my screen. I'm just going to share the screen and we're just going to walk together. Don't look at the names, okay? No. We're just going to go together from I'm just going to put MRI here. I'm going to put a spine. And when we're just going to randomly open some. Okay, let's open some random MRIs. So, okay, let's see what we have here. So this is an image with our 3 Tesla. I don't even know what we're going to find, guys, so bear with me. Okay.
Pessoal, o Maximiliano perguntou, você pode mostrar para a gente uma hérnia de disco típica? Então, a doutora Anne está buscando uma ressonância no arquivo dela para mostrar para a gente, tá bom? E after I'm going to ask Oscar as well, he asked you, if you suspect Warburg disease, which one do you prefer? CT or MRI if the owner can't afford both procedures?
Yeah.
Is it necessary, both procedures for the...
No, it's not necessary. So on this MRI, for example, that I was showing you, this is not a typical because this dog has do you see there is some bleeding on the top? So this is one of these explosive discs that What happened is that they are just kind of all around the spinal cord. So you see that black. So you see here, what you see typically on the T2, this is a stair, this is a T2. What you see is that the disappearance of the dorsal column, of the ventral column, so you know that something is happening right there. And what you can see here, instead of having a ventral compression, the disc has exploded and is going a little bit over there. So that is a typical one of these explosives that they go through different spaces. Let me see if we have any Daxon. Okay, I have a Daxon here. I'm sure that is going to have one of these nice big discs. I'll show you. They are all the same, exactly.
Dachshunds é uma maneira que eles falam, é como eles chamam Dachshunds, né, pessoal? A gente fala Dachshunds aqui. Tekel, salsichinha, e lá se pronuncia Dachshunds. É bem legal o jeito que eles pronunciam.
Okay, so here I'm going to show you. So you have, again, this is something that, why can't we do the whole spine? Because we have a 3 Tesla MRI. You should absolutely not try to do this with a 1.5 because you're going to have horrible images, okay? So here, if you see, if I go a little bit lateral, so I go lateral, I see all the fat all around. But then when I go to the other lateral, I see that there is some material there. Can you see, guys? There is some material there on the side, okay? So we're going to do some transfer images at that level. So this is the spinal cord. It's a very small taxon, so it's not amazing quality of the spine. The smaller that is the taxon. Okay, so these are not the... So then we have the spinal cord, and then you can see that we have the spinal cord, all the fat around. And then, oh, these are not, it's not the best example with some pieces there. Sorry, let me try to get a big dog to show you because this is not, these are not the best. Welsh Labrador. Okay, a Labrador should have a nice big spine, hopefully. I hope that we're not going to find, or maybe if we find a tumor. Oh, this is not a disc. Okay, I will try to find what I'm answering. Let me unshare the screen, and then I can look some more this while I'm answering the wobblers. So the wobblers, I personally prefer 100% the MRI because you want to see how the spinal cord is affected. And remember that we have 2 types of wobblers: the one that is the osseous form. So the one that is the articular process, that they are going inside the canal, which I can show you very quick some difference between the 2 types of wobbler. So you definitely want to do the MRI because you want to see what's going on inside the spinal cord. Let me... And then you have the caudal cervical spondylomyelopathy, the kind of the instability one. And on the instability one, what happens is that you have that C6 that it tends to kind of be a little bit kind of hitting the spinal cord. You have all the spondylosis, and you want to see that edema inside the spinal cord. So let me share you the screen here, and I'm going to show you some examples of the different type of wobbler. So this wobbler that you can see here, this is a typical dog, which is, I'm going to show you how this dog is walking. This is, these tend to be very young dogs, okay? So these are the dogs that they have the forelimb ataxia, okay? They are very young. They are large breed. They are mastiff, but you see how ataxic, even a little bit hypermetric on the front limb. So these dogs, they have the osseous form of wobblers. So what happened? Do you see that dorsal compression there? So you have articular process. You see that articular process are really impinging the spinal cord. And sometimes you have the ligamentum flavum that is also compressing there. And what happened is that the spine, instead of being nice and round, is a square or is triangular, okay? So this is very painful. All your discs are completely normal. They are healthy because it's a young dog. They are hydrated. Are you going to see this one on the CT? Yes, of course, you're going to see this one on the CT. And it's true because they are very young. You're not going to see much inside the spinal cord. So you could get okay with a CT. But with the MRI, for me, it's even better. Remember, if you do MRI and if you do CT, you need to do transfers in every single space because usually all the articular processes are affected. Then we have the other type of wobbler, which is the caudal, which is when you have the 2-engine walking. You see that dog with the little steps on the front, okay? And the wide range in the back. So this is a typical 2-engine of the caudal spondylomyelopathy. How does a caudal spondylomyelopathy look like? It's not this. Oh, yeah. It's this one. Okay. The thing is that I'm not sure that you're gonna be able to see it here that well. Okay, so what you see here is a vertebra that is very shortened. Then you have a little bit of compression, but you have an intraaxial lesion inside the spinal cord. So you're not going to see that on the CT scan. You're going to see that there is a little bit of a shortened vertebra, that there is some spondylosis, but you're not going to really know, and you're not going to be able to evaluate how much compression, because these discs are fibrotic. There's not a chondroid degeneration. So I think that it will be very difficult to interpret this type of wobbler, the one that is the caudal, is older dog, and is more like a chronic disease. I think that it will be very difficult to interpret with the CT. So my suggestion, if you can, do an MRI for both, because the MRI will give you the answer for both cases. And if you do have this intraaxial lesion, then it could be gliosis, it could be edema, so it could change the way that you're gonna fix this dog. So this dog, what we did is we put a spacer, a titanium spacer, and we put a plate over it. Because the space, you can see that it was completely collapsed, and you see how the vertebra was the space was completely collapsed. You have a lot of spondylosis, and the shape of the vertebra is very reduced too.
Wow, awesome. Great. Dr. Ane, we have a couple of questions. Would you mind telling us, what do you think are the difference in the sensitivity between myelotomography and CT with intravenous contrast for extradural lesions?
Yeah, so if you're looking for an intradural lesion, intraaxial lesion, you definitely need to give contrast intravenously. You want to see if you're lucky, and if it is a tumor that will uptake the contrast. So the myeloscan, I think that you will only need it if you cannot see anything. So if you do your CT and you can already see that in an area there is something happening, then I will just give the intravenous contrast. So it's a completely different, like the intravenous contrast obviously is just going through the blood-brain barrier, and the myelogram is just going to do it's just like doing a myelogram. It's just going to tell you what's going on in the dura. So if you suspect there is something in the dura, do you really need the myelogram? If you think that, oh, there is something intraaxial, my spine looks big, but I don't know if it's in the dura or if it's inside the spinal cord, I agree that probably the myelogram will be better, but unfortunately, I am not bad, I would say. I'm in a situation where I don't need to choose, and I do MRIs.
That's awesome.
So unfortunately, I don't have a lot of experience with trying to find a solution with the CT scan. But I will think that, yeah, if you want, if the spine is kind of big, I will think that probably the myelogram will help you a little bit better, because there's not many tumors that they're really going to take the contrast inside the spinal cord.
And okay, two people asked, what program do you use to see the MRIs?
So this one that we are using at Tufts is, which one is it? Oh my God, do I need to close it? I think that is PAX. Let me see, Carestream, PAX. But then, I mean, when I'm using my Apple, I use the Osirix. And then also, I recently download, what's the other? There's another one that is also for free from Apple. That is even, I mean, it's like the Osirix, but you know, the Osirix is all the time asking you to buy it.
Yeah. Is it the For Apple, I think they use the e-film, right?
No, the e-film is for e-film. I've already used it and I like it a lot. That can be for, but the Osirix is a free download for Apple. And let me try to see if I can find the name.
Is it Autos?
Yes, exactly. Oros, yeah, exactly. And it's true that I prefer Oros because with the Osirix, yeah, you just need to be uploading, upgrading. But those are for free. And eFilm, you need to pay. Obviously, I love it. The one that we use here, the university pays the CareStream, and it's very nice. But for free, Osirix and the Oros are very good. Yeah.
Awesome. Pessoal, a gente perguntou à doutora Anne qual programa que ela usa. Ela falou que ela usa o Horus, o eFilme. E também a gente perguntou sobre a sensibilidade do contraste na mielotomografia, né, com contraste intravenoso, ou a mielotomografia na tomografia computadorizada. E ela resumiu, né, que em alguns casos tem que avaliar se você tem um suspeito ou não na dura, mas ela não precisa mais escolher porque ela tem ressonância, tá? Another question that we have. Do you mind if do you still have time for us?
Yeah, of course, yeah.
Let me see here. Isis asked, what are the symptoms or the clinical signs that you consider in a patient with meningoencephalitis, granulomatosis meningoencephalitis? We call it MAG here. I don't know how.
Yeah. So the most common one is vestibular dysfunction. So anytime that you have a vestibular dysfunction, doesn't matter what is the breed, doesn't matter what is the age, you need to be thinking GME. Definitely, that is the most common thing. Seizures, not that common. Vestibular ataxia, head tilt, they tend not to be very dramatic. It tends to be like a little bit wobbly with a little bit of head tilt. It's not like horrible. And you need to remember also that we're starting to see more and more multifocal spinal cord and brain. So you may see these cases that they are vestibular, but they also very paretic. So vestibular, I will say that is the most common neurological finding. Yeah.
Awesome. And Alessandro also asked, is it necessary dynamic images when I use MRI, or can I use one position in wobbler disease?
Yeah. Very good question. I have an opinion that it may not be the same opinion as other neurologists, definitely not the same opinions as surgeons, but I think that as a neurologist, we know a little bit more what's happening with the spine. So that's why we like the spine. That's why we like the MRI. And I think that surgeons, they will tend to like the CT, and the neurologists will like the MRI. Why? You see that image that I showed you before with that intra-axial lesion of the spinal cord. That was telling us there is some edema or gliosis. That is telling you that that has movement. That spondylosis that you have there, that shortening of the vertebra, you have all that secondary lesions that they are telling you that that area is not stable. So in my opinion, you don't need any traction views on that dog. You need to remember also when you do traction views, obviously, you're going to stretch the disc. The disc is going to go down and you're going to have a resolution of the compression. That is just normal biomechanics of the spinal cord. So this is why if you have an MRI, you're going to be able to see all that secondary lesions that you have, and that is going to prompt you towards, okay, this seems a little bit more like unstable, a chronic, a little bit of, chronic disease. And you need to also look at your clinical presentation, because I have also had a dog with a wobblers on the MRI, but the dog came for a peracute, super painful tetraplegia. And that dog had, and I have the MRI somewhere, this dog had wobblers that was there for months or years, and then had an acute disc a little bit higher up. We did a ventral slot on the disc higher up. The dog was walking in 2 days, and I did not touch the wobblers. So again, you need to localize and you need to do your differential diagnosis, because this dog could have had traction views or whatever, and what this dog needed was just a simple ventral slot on the acute disc that he had. So I don't like traction views. I think that there is one paper from Da Costa that is very good, where he has designed this board with the specific positions of the head and all that for specific views of the cyst on the synovial space. But I don't think that we understand enough the how much traction you need to do, how much weight you need to do. So yeah, I think that the interpretation is going to be very subjective, and I think that you can get a lot of information if you know how to read the MRI and the clinical history.
Okay. There's two people. Isis is asking, do you have a case of meningoencephalitis, granular meningoencephalitis? How do you say it?
GME.
GME, yes. Do you have a case of GME?
Yeah, we have.
I think we're going to end with this, another one, the last question maybe. Glaucia is asking, I would really like to see the atlantoaxial luxation that sometimes you consider normal. I don't know, maybe you know better what she's talking about.
I think that I have, one of the images that I was going to show you. Let me see. Okay, so let me just share. I'm just going to one of these clinical cases that we do with the students. I know, sorry, I just shared the wrong screen.
It's a lot of buttons there.
Okay, so this is a typical case of GME where there is too many things going on. So first of all, this is a T2 sagittal image of the brain and the cervical spine. So few things you have. First of all, you have an overcrowded fossa with a little bit of a herniation of the cerebellum. So this is a Chiari-like malformation. And then you have an intraaxial hyperintense lesion, which could be consistent with syringohydromyelia or edema. And that's why we will do different images. When we are doing the transfer images, we have a T2 and a flare, and then we can see at the level of the thalamus, lateral ventricles, third ventricle, hippocampus here. So you can see this hyperintensity on the thalamus. So this is typically what you will see on GME. So this, and then you can see also here on the brainstem, like this heterogeneous hyperintensity at the level of the brainstem. So this dog probably also has some neck pain, some kind of changes, chronic changes related to the Chiari, but this thalamic and the brainstem probably was giving him the typical vestibular signs. So this is what we see on the GME, heterogeneous at the level of the brainstem. This is the aqueduct, okay, lateral ventricles. So this is already the brainstem and this heterogeneous area over there, which is a little bit caudal to the one before. And then this is our T1 post-contrast. Look at these meninges. They are on fire. They are all taking the contrast, the meninges there. And then you have that patchy, okay, that patchy contrast enhancement around the medulla and a little bit of the cerebellum. So this is a typical example of a GME case, which they have more than one thing. They also have Chiari, they have otitis. So that's why you need to localize and do your differential diagnosis, not to now say that this dog has Chiari and do a surgery for Chiari when he has GME.
Okay, awesome. So Glaucia, she's saying that sometimes what is considered luxated and normal, it's a little controversial. So she wanted to ask you about, the atlanto-occipital luxation. What do you consider? And if you have...
So my 2 cents that I'm gonna say about that, which maybe is not what she wants to hear, but because I'm gonna create more doubt on her than giving her an answer. But this is typically what you may find if you do an MRI of a dog that has an atlantoaxial luxation. Why I'm putting this MRI? Because these dogs, they don't only have an atlantoaxial luxation. Most of the times, you have also a quadrigeminal cyst, you have a dural compression, you have a Chiari malformation, you have hydrocephalus, and you have secondary syringol hydromyelia. A lot of these cases, these toy breeds that you may only see an atlantoaxial luxation on the x-rays, they have very complex malformations. So I know that there is a recent paper that was very interesting from Tim Bentley regarding how to do the measurements on the atlantoaxial area. Again, these cases, we also do an MRI. We don't only do an X-ray. So I am absolutely not the person to give advice about interpreting an X-ray of atlantoaxial luxation. My 2 cents will be careful, because it may not be the only thing that you have there. And what do you consider normal or abnormal? I don't know. I will ask Tiago next year.
Yeah, I think she was referring atlantoaxial, not occipital. Do you have any?
Yes, but the atlantoaxial, but when they have a hypoplasia of the dens, they tend to have other things too. You also have, particularly that this dural compression here. These guys is extremely common. The dural compression on the atlantoaxial luxation too. So, and that can also provoke a lot of problems into the dog.
Awesome.
Yeah.
I think you answered. So last question, since we asked everybody, not going to leave Guido without an answer. If you have a presumed or idiopathic epilepsy, or ruling out idiopathic epilepsy, do you use any special protocol, or do you ask something special to the radiologist?
No, so we do a protocol. It's true that in school we tend to do a little bit of a longer MRI because we want to have everything in case we're going to do studies. But there are some protocols published on the canine, on the veterinary epilepsy task force. But no, you want to have a protocol. So my minimum protocol will be T2 for a brain, will be T2 sagittal, T2, T1 flare transverse. That will be the minimum. And then I will always do contrast. So I tend to do dorsal T1 pre and post contrast and T1 transverse pre and post contrast. I don't do dorsal T2. I'm happy to do only the sagittal T2 and then dorsal T1 and then transverse of the T1 flare and T1. And then if you're suspecting a bleeding, you add the GRE. And then here, for example, at TAFs, we always do the diffusion weight images because we want to do a lot of studies. But I don't think that for an idiopathic epilepsy, we actually, the radiology service did some studies and they were able to do like a 30-minute protocol for an epileptic dog with a very, very low probability of missing a lesion without giving contrast. But we like to give contrast to all the brains, to be fair. And I will recommend that to give. But then remember, guys, if you give contrast, you need to have something to compare. You need a pre and post. Otherwise, there's no point.
Awesome. Well, Dr. Ane, I have no words to thank you. It was awesome. People really enjoy it. You can tell by all the questions that they made. So thank you very much for all your answers.
Thank you, guys.
Thank you for accepting the invite. It was great. I hope to see you in Tufts real soon. Hopefully you'll be there. And the last question is my questions. What's next for you?
What's next for me?
What are your plans for the future?
So my plans for the future is that I'm going to move back to Europe and I'm going to be the head of the neurology service of a new hospital, of a big hospital. I'm going to be doing a little bit of teaching at TAFs, especially with the online teaching. And then hopefully I'm going to continue doing a little bit of research with some universities in the UK, and obviously keep doing Instagram and Facebook and everything.
Awesome. Well, thank you very much. I hope to see you soon. I wish you all the good luck in the UK. I feel sad that you won't be much time in Tufts, but I wish you all the best.
Yeah, but we will keep in touch.
Yeah, we'll keep in touch, definitely. And maybe do some more lives, right?
yeah, exactly. No, these things are nice, and it's very nice, guys, that you are asking questions, and they were very, very good questions. So thank you so much for that. Yeah.
Well, I appreciate it. Thank you very much, Dr. Ane. See you. Bye. Take
Thank you.
care.
Have a good night. Bye.
Have a good night. Bye.
Bye, Annie. Thank you.
Bye.
Gente, obrigada.